Lovely people, there's no time to waste. We only have 35 minutes left with Prof. Rez.
37.
No, it's 9:02, Prof. Rez. Don't question my math publicly. Yeah, guys, we're so excited for another RLR, but a little sad that Prof. Rez won't be here for the last 23 minutes. So we will speed to the case
I've
presentation.
never seen you do math correctly so quickly. I'm really impressed right now, man. Today's going to be a good day.
Yes, sir. I'm ready. You know why, Prof. Rez? Fuel. It's all about what you put in your body. Anyway, I will probably move on to another breakfast addiction in the near future, but it's nice to be able to log it on VMR. Today, Parisa switched from the case discussant role yesterday to doing our teaching points. David is in the scribing seat, and the one and only Maddie, who I will get to hang out with tomorrow, is presenting a case. So without further ado, let's rock and roll. Maddie, the screen is yours, and Prof. Rez will bamboozle us with the first aliquot.
All right. So the chief concern that this patient had was difficulty walking. And a brief, so jumping into the HPI, so this is a 41-year-old man who was brought in by ambulance to the ED in a wheelchair. And the patient actually called the ambulance himself because of difficulty walking and the feeling of leg weakness. The story that was obtained in the ED is that a few hours prior to calling the ambulance, the patient smoked crack cocaine. And then over a period of 1 to 2 hours after smoking crack cocaine, he started noticing difficulty walking and a feeling of leg weakness, which is why he called an ambulance. And I will pause there.
Wow. First of all, good morning, Maddie. Hope you're doing well. I see a
Good
really nice
morning.
view in the background.
I'm visiting my mom in San Francisco. It's a beautiful day here.
Doesn't get better than that.
I know.
Question, do we know what his functional status was prior to this?
So yeah, so he's not wheelchair bound at baseline. He is able to walk normally.
That's so helpful. So we often talk about stuff like syncope, where we like to know pre-event and then the event and then post-event. The same thing applies to someone with difficulty with walking. You want to know what is their baseline functional status and what that delta is, because that will alert you on how concerned to be. And I think the tempo is also very important here, Robbie, and also the sequence of events. Like we know that prior to this, there was substance use. Then the patient developed symptoms, which prompted him to call for assistance. I think the mistake that you can potentially make here is to automatically link the substance to the difficulty walking. Yes, that should be entertained, and that will make it on the DDX, but there's a good chance that this patient has been using the substance in the past and never had an event like this. So we have to explore beyond substance-induced a clinical phenomenon. In fact, I have a patient on service right now, which I won't say more about because it will be presented to Robbie. On Robbie's so many good cases. You have no clue, my friend. But here, when we talk about weakness, we always say, is it true weakness or is it asthenia? And I've started going away from fancy terms. Like today in my note, I didn't write first metatarsal. I just said big toe because we need to understand what we're saying. So I'm not going to use asthenia. What the heck does that mean? Like, is this weakness due to a neuromuscular lesion? Or is it weakness due to another chronic medical condition? Something that really helps you to say that this guy is actually weak is he's complaining of focal problems. Like, I can't walk. So that suggests to me that there is true weakness, and I would prioritize that over just a feeling of weakness. And maybe what I'll do now, because I've spoken enough, is pass the mic to Robbie to either continue along that train of thought or change it up a bit.
Prof has absolutely nothing to add. I'm just planning on the next step and what would be the most helpful as we try to localize this lesion, either as a neurologic one or not, but with a hunch towards a neurologic one, a strong hunch because of the focality, as you so eloquently said. And I think that I made this mistake before. If somebody is being put in a wheelchair to compensate for what's going on, you have to uncompensate them temporarily. That's what orthostatic vital signs are, right? When the patient tells you, I get dizzy when you stand up, you don't just say, oh, no, I'm never going to make you stand up. You're like, just bear with me 1 minute, please, while I make you stand up and see what happens. So I will tell you the single most important test is not the detailed neurological exam right now. It's let's remove that compensatory mechanism temporarily in a safe, monitored environment and see what happens. And I think that'll be really, really key because practically speaking, once the patient makes it into the bed, has a monitor on them, has an IV in them, has a blood pressure cuff on them, has all the noise, the ability of you to undo all that and to have them walk is much, much harder. So before the patient goes into a bed and has an IV in, please, please, please try to see what happens when you remove the wheelchair. It is of profound importance, and it's on my mind because, speaking of future RLR cases, a lesion in that step in a different case scenario was why a patient had a significant delay in diagnosis and outcome that I made an error yesterday. So it's really, really key not to lose that moment. All right, Maddie, back to you.
All right, so for more of the HPI and review system, so he did not report any recent falls. It's really this difficulty walking that came on suddenly that he reports. So no chest pain or shortness of breath, no sensory changes, and no nausea, vomiting, diarrhea, or a headache. When asked about changes in urinary frequency or color, the patient says that he hasn't urinated since the day prior. In terms of past medical history, so he has a past medical history of stimulant use disorder, usually cocaine. He also has a history of schizophrenia versus schizoaffective disorder, not currently on medications, and not reporting recent auditory or visual hallucinations. For surgical history, he has prior amputations of several digits, both the fingers and the toes, as a result of frostbite, unfortunately. Does not take any medications daily. And for kind of family history, unknown. For social history, so he's currently unhoused and often lives on the streets versus shelters in Denver, Colorado. And he reports food insecurity, so he actually has not eaten, he said, for around a day or so prior to coming to the ED. For health-related behaviors, so the team got from him that he smokes 1 pack of cigarettes per day, and he smokes crack cocaine monthly to weekly, he says. No alcohol or IV drug use, and no allergies. So for vitals in the ED, the blood pressure was 110/90. The heart rate was 92, respiratory rate of 20, and the patient was saturating 96% on room air. And so this is the physical exam as documented in the ED. So overall, the patient was quite ill appearing with a flat affect. Nothing notable on HEE and T exam. Cardiovascular was normal without murmurs. Pulmonary was clear to auscultation. Abdomen was soft, non-tender, non-distended. For neuro exam, so the neuro exam was documented as bilateral lower extremity weakness, proximal greater than distal, with 2 out of 5 strength in the bilateral lower extremities proximally and around 3 out of 5 strength more distally. There were no other deficits on the neuro exam, so no deficits noted on cranial nerves or sensory changes. And then for the kind of extremities and skin, so several digits, both on the bilateral feet and on the hands, were noted to be amputated. There was no edema. And then adding from kind of later when I saw the patient, he had these kind of chronic wounds on like the extensor surfaces of the elbows that were chronic. And I will pause there.
Prof, honestly, since you have to leave so soon, I'd love just to have you start first and take as much of this as you can, and I'll reflect too with you. But
Oh,
here's some
honestly,
magic.
let me ask you this question, Maddie.
Yeah.
Do you think we can finish this in 45 minutes, like by 9:45?
Yes, I think
All
so.
right. So Robbie,
Because the
stick to the
next
plan.
just 2 more aliquots, yeah.
Tackle it like a mathematician would.
Oh, when we have Maddie here, I think we can definitely uh, dissect this case with just a little bit more of velocity. Yeah, I think um, where I would be honestly inclined to start is not so much the medical history, but the exam. And so maybe I can just reflect on what the exam says. Um, and I think when we see that the patient has lower extremity weakness, the presence of lower extremity weakness really prioritizes a myelopathy or a cord issue. I say that because if you have a neuropathy has no real reason to preferentially affect the lower extremities alone, unless it is affecting the lower extremities because of the length dependence and the legs are longer than anything else. But once the weakness starts to extend above the knees, a length-dependent neuropathy is no longer at play. And so you're immediately already thinking, hey, okay, whenever I have severe bilateral lower extremity weakness, I have to think cord or nerve roots, especially cauda equina. So it's the two C's that should be your reflex when somebody has bilateral lower extremity weakness, but that might change here to some degree because of the proximal predominance. And the proximal predominance should move you more distally into the neuromuscular junction or more likely the muscle. So in other words, most patients that we take care of who have weakness have a nerve problem. But when it's severe bilateral lower extremity weakness, prioritize the two C's, cord or cauda. But here the proximal predominance has you going on the other side of the localization arm, further to the distal aspect of the nerve, to the muscle and the neuromuscular junction. And so I think that the reflexes here would be very, very telling and would help you try to figure out if that is the case. But the reflexes are often hard to interpret in an acute paralysis. So strictly speaking, when you have a cord issue, your reflexes will be up. When you have a cauda issue, your reflexes will be down. And when you have a muscle issue, your reflexes will be normal. But those rules are only applied to patients who have defined their physiology and allowed it to evolve over time. And there are many exceptions to the rules, especially in acute disease. And so I think the only aspect we don't know of yet, we've analyzed the sensory system, we've analyzed the motor system, we likely will not have the reflexes. That's commonly not available. But the other aspect to invoke is autonomic. And so I think there was a possibility of an autonomic feature on history with the lack of urination. And the vital signs are not quite cardiovascular dysautonomia, but they might evolve to that. So I would say the exam, morbidity of the exam would have you prioritize the cauda or cord. The probability of proximal predominant weakness suggests the muscle or less likely the neuromuscular junction. The way to tease them out as an expert neurologist would be to invest heavily in your ability to be confident about your reflexes. But more practically, as a generalist, you might invest in a CK, which might also connect with the lack of urination that we received on history through other means, not obstructive uropathy. And then if the CK is disappointingly not explanatory, I think rapid assessment for a central lesion that captures both the cauda and the cord would probably be the way I go about this. There are some other things that you might do that are less common, and we can talk about them in the future. But the one really, really important thing, if you're thinking muscle, is in addition to getting a CK, to get not just your basic metabolic panel for a potassium, which is relevant in acute myopathy, but also for phosphorus, which is relevant for myopathy, especially in a patient with food insecurity. So I would say my next action steps based on the exam alone are CK, potassium, phosphorus. If disappointingly unexplanatory or not explanatory, central imaging. But there's the medical history is really interesting, and I'm curious what you made of the exam too, Prof. Rez.
Oh my gosh, what is left to analyze? I think that was such a great journey through the neurologic exam. And I think, with that urinary retention, I hope the ED did get that MRI with gadolinium to just evaluate the cord. but 0 tag.
All right, amazing discussion. So we'll give you some initial labs here. So the CBC, the white count was 12.6, normal differential. Hemoglobin 12.3, and platelets were 119,000. For basic metabolic panel, the sodium was 129, the potassium was 5.2, and then rose to 5.8 on subsequent lab. Chloride 102, bicarb 10, BUN 52, and creatinine was 6.3. The last creatinine documented was 4 years ago, and it was 0.97 4 years ago. Anion gap of 17, and a calcium was 5.6, ionized calcium of 0.89, mag of 2.4, and phosphorus 7.8. And I can show, I actually have the EKG that I can show you. And then I'll pause here to let you interpret those labs before I give you more labs.
Robbie, do an ED interpretation of this EKG.
Oh yeah, my reflex interpretation is that this EKG does not really sway my needle too much. I think what I was looking for is any screening ischemic changes, with the pretest probability was low. I don't see any evidence of peak T waves. The QTC looks okay. Yeah, it is a little fast, and the PR interval is a little short. But honestly, I don't think I would. Yeah, I look forward to learning if this EKG is interpreted differently. But for me, I would be like, noted, nothing alarming yet. Or yeah. All right, Prof. Rez,
Yeah,
you're
so
up.
I'll just give a brief. Yeah, go ahead,
Oh,
Prof.
sorry, no, go ahead, Maddie, please. I thought you were.
No, I was just going to say on the EKG, and I may have pulled up because there were a few that were obtained, but it showed peaked T waves and a slightly prolonged QT of 524.
No, duly noted. Okay, so Robbie, I didn't pick up on those. But anyways, to talk about this, you know what? It's really interesting here is the labs, Robbie, and interpreting the labs in the context of the physical exam. Like, you look at the potassium, it's elevated, and then you quickly reflex to the creatinine, and that's elevated. So the high potassium is explained by the high creatinine. You look at the sodium, it's low. Oftentimes there could be multifactorial causes, but you have a real good cause, the kidney injury and the inability to get rid of fluid. So, and then you look at the phos is elevated. Look at the creatinine. That's what you would expect. The calcium is low. Again, look at the creatinine. Here you have to be a little bit cautious, because what does the kidney do to vitamin D25? It activates it to 125. Vitamin 125, vitamin D 125 is required to absorb calcium from the GI tract. So in patients with CKD, they're often hypocalcemic. And this is what stimulates PTH secretion and how you get in trouble with tertiary hyperparathyroidism, which then activates osteoclast that leads to osteoporosis. And Rob is wondering, why am I even talking about osteoporosis and osteoclast? But it's just a cool teaching point to make. But I say the law, but there's, okay, so the focus is the kidney injury. That's our focus, right? That should be everyone's focus, because it explains so many of the other abnormalities. And I slightly will pause with the calcium, just because, who knows, maybe it's not proportionally correct, but I'm going to table that for now and just focus on the kidney injury. Then the next question is, well, is this kidney injury acute, chronic, or acute on chronic? And also, can this kidney injury explain the clinical syndrome? No, it can't. How many patients have you seen with kidney disease come in with acute onset lower extremity weakness? It's just incompatible. Remember, hyperkalemia is usually a silent process. It's a laboratory finding. And his K isn't even that high. It's 5.8. And he didn't have severe hypokalemia, which can lead to some, muscle weakness. And really the question becomes why the urinary retention? Because this is probably obstructive uropathy leading to kidney injury. So this patient needs a stat Foley insertion. And if a liter or more is not drained or the creatinine doesn't improve, then you can step back and ask the question, what else is driving the kidney injury? Do you agree, Robbie? Like, I feel at this juncture, these labs are just a sequela of whatever is causing urinary retention and the lower extremity weakness. So it doesn't really sway me in any particular direction beyond you got to look for the two C's, cord compression or cauda equina. So the next step is an MRI with gadolinium. Without is not helpful. And remember, the type 2 gadolinium agents are not linked to nephrogenic systemic fibrosis. What do you think, Robbie? Do you think that calcium is disproportionate to this degree of kidney injury? And how do you go about acute versus chronic? I mean, talk about anything you want, but I would love for you to tell us. You just get a creatinine, you don't have a prior. How does your mind as a ED doctor think, is this acute, is this chronic?
Yeah, Prof. Rez, I think that I think for me, I when the creatinine, we talked about this yesterday, ironically enough, I think when the creatinine is when the patient has chronic kidney disease, they often unfortunately have sarcopenia. And if you picture in your mind's eye the number of dialysis patients you've seen who have a low BMI, I'd say most of them. And so that sarcopenia often means that despite the fact that they have no renal filtration, their creatinine is never super high. And I suspect that a patient who at baseline has food insecurity is at risk of sarcopenia, significantly so, that he would be able to dump enough creatinine to cause a creatinine of 6.3, I would say that the only way that's possible is if it's acute. Because I'm picturing somebody who's cachectic probably at baseline, who develops chronic kidney disease and makes him even more cachectic. It's hard to imagine that his creatinine could hit 6.3. Possible, but that's why I would say that I think that I'm leaning more so to acute. And I think it's interesting because we know he hasn't urinated since the day prior, and it's very tempting to say that that's urinary retention, especially in the context of weakness. Gosh, I can't wait for that PVR or the Foley, because it could so easily be so that he doesn't have a blockage of his ureters macroscopically, but that he has a microscopic tubular occlusion. And this is actually a concept that I'm seeing play out a little bit more about the ureteral obstruction. And it actually stems from a case that Prof. Rez presented on RLR of a patient who had tumor lysis from a myeloproliferative neoplasm, who both had a macroscopic stone caught with urate obstructing stone, and also had tumor lysis from microscopic urate crystals plugging all the tubules. And so I would say that an obstructive uropathy is very, very likely here given the height of the creatinine. And I'm wondering if it's a macroscopic obstructive uropathy with a positive PVR, or a obstructive uropathy of microscopic proportions where the tubules are plugged with something. And I think in the context of it being proximal weakness, I would worry about another C, the CPK, as the next step. I don't know, Prof. Rez. What CK would push me away from getting an MRI? I don't know. That would be a very hard decision, but I think this case just illustrates how CPK is not part of most of our first pass workups, but I think it probably would be very helpful to have it now, to try to make that decision of MRI or no MRI. I'm holding my breath until that comes back. Yeah. All right, Maddie, I'll pass the mic to you. What do you got next?
All right. So the CK that you were asking about, so the CK, the first measurement was 162,000. And then on subsequent measurements peaked to 205,000. Other labs, the AST was 1,000, ALT 262, LDH 4,063, uric acid elevated at 19.7. And what else will I share? The CRP was 100, and a bladder scan showed 140 cc's. And after 1 liter of fluid bolus, only increased to 150. And they got a renal ultrasound as well that did not show any hydronephrosis, but commented mild echogenic kidneys with trace bilateral perinephric fluid. And I will pause here.
It's really, really intriguing twist. And I think if we were to sort of summarize what we're left with now is we had a patient who presented with acute weakness of proximal predominant and found to have likely acute kidney injury. And I think we found the unifying underlying feature, which is that the patient has rhabdomyolysis with a marked elevation of CK. And that explains the weakness because the muscle is leaking its enzyme. And then the CK poisons the kidney, causing the kidney dysfunction. And so I think there are two parallel threads of open questions. The first is, does the height of the CK have any clinical significance here? And what is the ultimate cause of the muscle dysfunction? And then what do all these other labs signify? And I'll just take a moment to talk about the other labs and what they mean. I'll pass the mic to Prof. Rez to see what he would be thinking about what the muscle injury is and where he would go from there. And I would just tell you to ignore all the other labs. They are of no relevant significance. And you might say, wait, I know LDH can be a cancer, and you're right. I know an ALT that high can mean acute liver injury, and you're right. I know CRP can mean tumor lysis, uric acid, and you're right. But all those things come from muscle. And in a patient with otherwise normal liver function, otherwise no evidence of cancer, I would say that the source of the AST, ALT, especially given the ratio of AST to ALT, is muscle, muscle, muscle. So I would give you the advice not to focus on anything else but what Prof. Rez is about to talk about, which is the CPK.
That's fantastic. And I think that maybe a clue from the exam that it wasn't urinary retention was that the abdomen wasn't distended. And in reality, we're just doing an exercise here. You would have those labs, be it the AST and ALT at time point 0. So you wouldn't even have to make that step if I'm going to wait for the CK to decide if I'm going to do an MRI or not. But the AST is going to be fluidly positive, and it puts you down that path of rhabdo. And if we did our cognitive autopsy, if that reflex was normal too, which we would expect it to be, then you can eliminate the two C's with the AST and ALT and focus on what's causing acute onset rhabdomyolysis. But the lesion of my thinking was just no urination means there's retention, but that's not the case. It could mean that the kidney is just not being perfused for one reason or another. And his age is quite young for the common causes of urinary retention being BPH. So then the question becomes, what's causing his acute onset rhabdomyolysis? It's important to note that to give the diagnosis of rhabdomyolysis, the CK has to be north of 5,000 and probably 10,000. Like, you have to show that the myoglobin is causing trouble to the kidney. And really, management becomes important here because it's the electrolyte derangement that leads the patient to have really life-threatening consequences from the exact abnormalities you see here, be it the hyperkalemia, the uric acid, the hypocalcemia. So management-wise, you're going to be treating these conditions, but the most important treatment is going to be fluids, like in a lot of fluids, not like internal medicine fluids of 100 cc's, 125 cc's. You're going to be giving this patient 150 to 200 cc's per hour, just really increasing urine output. And other things that will be considered here is uric acid lowering agents, allopurinol, or other agents to quickly, respiricase to quickly bring the uric acid down. because that's really what's leading to the AKI, is that, as Robbie eloquently mentioned in the previous aliquot, it's the crystallization. So this person would get flooded with fluids. You'd probably put them on a floss binder. You'd probably put them on a uric acid lowering agent. You would replenish their calcium stores. And that would be like probably the management component. As far as what causes acute onset rhabdomyolysis, in this case, my reflex is it's the cocaine and like the substance that either the cocaine itself or the substance it's been adulterated with. But then I'll pause for a second and not try to. Sorry, I have some little bit of French music in the background. We'll pause there a little bit and we'll say, like, could it be anything else? Well, when I run through my list of acute onset rhabdo, beyond medications and illicit substances, other common etiologies is trauma. Like I once had a patient who was restrained because of psychotic behavior, wrist restraint, and was like really fighting it and had a CK of 160,000. And honestly, that patient ended up actually needing dialysis because of this really profound abnormality. But there is no trauma. There is no other medication. The autoimmune stuff that can lead to CKs this high is really necrotizing autoimmune myositis. That's usually associated with statin and HMG co-reductase antibody, but there's no evidence of statin exposure, though you can get it without a statin too. And then viral stuff, like viral syndromes can lead to CK, but this is really, really profound elevation. And I can't think of any other autoimmune entity in the myositis, be it IBD, polymyositis. I can't really find any link there. Some endocrinopathies can lead to abnormal CKs like TSH. And I'm wondering, what would I do here? I would focus on managing. I would ask him where he's getting his cocaine, if it's from a new supplier, because maybe it's adulterated with something. I would prioritize cocaine-induced myositis. I don't know if I would investigate further. I don't have enough experience to know how to apply the law of proportionality. But I'm curious, Robbie, would you be sending any additional tests or?
Yeah, no, I don't think so, Prof. Rez. I think you outlined it so well. I think the likelihood here is very much like, I think the checklist is meds and toxins primarily. And so, no, I don't think I would be. I'm right there with you. All right, Maddie, Mike, to you.
Well, all right. So some of the additional labs you all mentioned. So a TSH was normal. HIV was also normal. And no urine drug screen was performed because the patient was actually anuric and declined a Foley placement. And then Reza, just to comment on your management, reasoning, exactly as you said, for the hypocalcemia, the patient was given, calcium gluconate and calcium carbonate, was given Lokelma. For the hyperkalemia, a phos binder, allopurinol for the uremia, and lots of fluids. And then just to kind of summarize the hospital, so just like for the kind of diagnosis that we all were considering here was rhabdomyolysis, presumed secondary to the cocaine use. And so just to share a little bit about the hospital course, so the patient was transferred to the MICU for emergent dialysis due to the electrolyte abnormalities. And so over a course of a week, underwent 3 rounds of dialysis. The CK, as I mentioned, peaked to 205,000, then came down to 5.6,000. And then over this week period, electrolytes recovered to the normal range. And the patient, kind of after stabilization, was transferred to the medicine floors after about a week or so, which is actually where I met the patient. And the patient's renal function did recover, and he started making more urine, and the creatinine kind of improved to 1.4. And when I met the patient on the medicine floors, a big challenge was for our team was kind of the patient's negative psychiatric symptoms and the lack of speech. So his affect was very flat, and kind of when taking a history or asking questions would respond with one-word answers. So it was very challenged to elicit a history. And so I found myself relying a lot on the history that was obtained by the ED clinicians when he came in. So actually, when I checked his chart this morning, I saw that he was admitted to the inpatient psychiatry unit for the management of really profound kind of negative psychiatric symptoms. Because I was checking a lot of the notes, and it seems like for a lot of providers, the patient basically wasn't talking. So, because of kind of the limited amount of information teams were able to get, the final diagnosis, as I mentioned, was rhabdo presumed secondary to stimulant use. And I did some reading and have some teaching points on that specific topic, but wanted to pause there just to hear any of your thoughts.
I think we should hear yours. Go for it.
Yeah, well, so for rhabdos, this is actually the first case of rhabdo I saw, and exactly as you said, I thought it was really interesting that the lab patterns are quite similar to tumor lysis syndrome because of the extensive cell breakdown that you have. So the cells break down and it releases potassium, phos. So you have very elevated potassium, phosphorus, and then the phos actually chelates the calcium, causing hypocalcemia. And of course, the high AST kind of disproportionate to the ALT and the high uric acid as well. So I thought it was interesting that I was kind of framing the labs in my mind very similar to how I think about tumor lysis syndrome. And then as you all mentioned, kind of in rhabdo, the injury to the kidney actually comes from the myoglobin, but it's the CK that we use as kind of like an indirect measure of the muscle injury to track it. And so then, I had never heard of kind of cocaine causing rhabdo. And, I generally think of causes, the most common cause as immobilization or trauma. And, we was not able to get a history of kind of trauma or severe immobilization. Maybe that did happen, but we just weren't able to get a history about that. But, cocaine and stimulants causing rhabdo is pretty well documented. And it seems like there's a few different mechanisms for how that can happen. One is from cocaine, and the stimulant is you can have arterial vasoconstriction that leads to muscle ischemia. And then kind of separately, you have this increased sympathomimetic activity, muscle hyperactivity, and hyperthermia. So all of those kind of mechanisms that can kind of lead to cocaine causing rhabdo. So yeah, that's everything I had, but really loved hearing your discussion of this.
Maddie, thank you. I actually didn't know, I don't know why I'm even saying actually, I didn't know the mechanism for how cocaine causes rhabdo. So thank you for teaching us that. And I love your point of it represents tumor lysis. And like this is on that differential diagnosis. So I really appreciate you bringing such a bread and butter case where management almost trumps diagnosis in this case. So I really appreciate that. And I really love Rabih's journey of like localizing the neurologic abnormality. It's either the cord, the cauda, or the muscle because of the proximal weakness. And yeah, and like really wanting that CK before ordering more tests. Good job. I want to just apologize to Parisa that I'm not going to be there to hear her teach. I have to go around with my team. Thank you all for a lovely hour.
Prof. Rez, you're such a gem of a human being. You see, guys, he cannot help but shower love on everybody else before he goes. So why don't we all give him a big shower of love? So get to your heart emojis, lovely people, and douse him before he goes. Let's go, let's go. Maddie, I just wanted to quickly say, I think that you're illustrating to us, I think, in so many ways how easy it is to learn in medicine. And I think it is nothing shy of absolutely remarkable that you take a case that is concluded in many ways and you extract so much learning from it because you were not involved in any part of the acute diagnostic or management part. But here you are reflecting on this case and all the things you learned from it and sharing that. And I really think this is the standard for what we're trying to do in CP solvers for a long, long time, is to really realize, yeah, Erdheim Chester is really cool and all these like diagnoses are really cool, but it's really these cases. and reflecting on these cases that allow us to actually realize that more common diagnoses are not at play in that patient with Erdheim-Chester disease. So I really, really encourage all of you to look back and ask yourself, if you have not presented a case or are on the fence about presenting a case, to really realize that we have yet to have a UTI. And the first person who presents a urinary tract infection on the CP solvers, I will personally invite you on a cruise to the destination of your choice. Okay. So thank you, Maddie, for really modeling that. And I hope it really pushes people to think about what we're really trying to accomplish here. And I would say this is the kind of case we want to reflect on as much as possible. So thank you so much for bringing it. Parisa, the mic is yours.
Thank you, Maddie. It was an amazing case and phenomenal discussion. It is really cool to see you in a intern position. I'm really enjoying it. We started with a patient who presented in difficulty in walking, and we learned that when we want to approach this chief complaint, we need to identify baseline functional status of the patient. And for example, when somebody is coming in a wheelchair, we will try to secure them and really assess their functionality before putting them in a bed and label them as this inability to walking. We need to also find out the delta of the changes, and we need to find out the sequence of the events and tempo of the disease. We also learned that inability to walk is interpreted to focal neurological problems. We also learned that we need to differentiate weakness from asthenia and neuromuscular lesion from chronic condition. We learned that when somebody with it's coming to us with severe bilateral lower extremity weakness, we need to think about nerve roots problem, radiculopathies, spinal cord problem, myelopathies, Kodai-Kuna syndrome, and muscle disorder, including neuromuscular junction problem or any myoglobinopathy like the problem, rhabdomyolysis we have in here. There are many ways that there are few ways that we could differentiate from these things I mentioned. One of them is the reflexes. For example, in the cord, the issues, the reflexes are high. In coda problem, reflexes are low, and the muscle problem, reflexes are normal. When the patient might present with autonomic dysregulation, which is happening with alterating in vital sign in cardiovascular dysregulation and lack of. When we are facing somebody with lack of urination, we need to do the bladder scan and do the MRI with gadolinium scanning. We also learned that in muscle disorders, CK is elevating, and we are having changes in basic metabolic panel, including sodium and potassium. We learned that in acute kidney injury, creatinine is elevating, potassium is elevating, sodium is low, like as this patient, because we are having water retention. And we also learned that acute kidney injury is usually incompatible with the neurologic exam the patient have. For example, in myelopathy and Kodai-Kuna syndrome, we do not have acute kidney injury. The other clue we had in this patient was that this a specific gentleman didn't have urinary retention with abdominal distension. It might be a clue to muscle problems. We also learned that chronic kidney disease might be accompanied with sarcopenia and low BMI. In this kind of specific patients, maybe creatinine never reached so high because they have food insecurity and cachexia in the baseline. We also talk about when CK is so elevated, the other lab element like AST, ALT lose their importance. We also learned that acute onset rhabdomyolysis is defined when CK is elevated 5 to 10,000 because myoglobin is actively injuring kidney. The notorious one is cocaine. Trauma could also do that. We are seeing that in autoimmune necrotizing pattern, a statin could cause this problem, and viral infection could lead to this, and also TSH. Maddie also taught us that the mechanism in cocaine-induced rhabdomyolysis is cocaine cause arterial vasoconstriction, ischemia, and sympathomimetics. We also talk about how to manage this specific condition. We need to overflow therapy our patient to 150 over 200 cc per hour to increase urinary output, and we need to use uric acid lowering agent like allopurinol. We want to prevent crystallization, and we are usually using phosphate and potassium binders reagent. We also learned that lab patterns in rhabdomyolysis is similar and compatible to tumor lysis syndrome, with difference that CK is elevated. Thank you so much.
Reza, poetry. You've become a pro at this. I hope you anchor this all the time. Thank you for peppering the fundamentals, and I really, really appreciate the management. I think that's probably the most important part of this case, and I think worth emphasizing at the end for sure. All right, guys, I hope you have a wonderful weekend and look forward to seeing you next time. Bye.